There's a little spot that says live, hopefully. Okay. All right, so hopefully we're going now. If we're, so hopefully you can hear me. Sorry, we're starting a little bit late. We had a little bit of some technical challenges, but hopefully we've gotten through those now. And thank you to Southern Hills Hospital for arranging this. My name is Dr. Jennifer Carroll. I am a general surgeon here in town. I work for Desert West Surgery, and we're going to be talking today about the history of breast cancer, especially seeing as this is October and it's Breast Cancer Awareness Month. I have no disclosures today other than the fact that I, like most people in our community, have somebody in my life that was affected by breast cancer. This is my grandmother, who was diagnosed over 10 years ago, who was very grateful to all the people that took care of her and for all the advances in medicine that gave her time to spend with her family. Breast cancer is the second most common cancer among women, second only to skin cancer. It is an incidence of 125 per 100,000 women, and we're going to see the majority of diagnoses in the 70 to 74 age range. The thing that we are most thankful for is that breast cancer is a survivable cancer. So our 5-year survival rate from breast cancer is 89%, but this has not always been the case. And so many advancements that we have made in medicine over the last several hundred years have led us to this situation today. And so that's what we're going to be talking about this morning. In the 18th century, there was a lot of pessimism around breast cancer. And so much of that was based on the fact that we did not have excellent cure rates. Sir James Paget was an English surgeon and a pathologist, and he had a special interest in tumors. And so one of the things that he looked at was breast cancer in general. And at that point in time, he looked at a study of over 200 women that showed that by 8 years out, nobody had survived breast cancer. So essentially this had a 100% fatality rate, and nobody could be cured. And to compound things, we didn't have the resources to even do surgeries that were safe. And so out of all the women that even underwent a surgical intervention or had surgery for their breast cancers, essentially, there was a 20% mortality rate. And most of that was because they would die from sepsis from a postoperative infection. So Dr. Paget actually said that the mortality associated with breast cancer was so high and that surgery was so morbid that we couldn't even justify even attempting a surgery to save the lives of women with breast cancer at that time. As we entered the 19th century, there were two advancements in medicine that really significantly impacted our ability to treat breast cancers. The first one was anesthesia. So the first anesthetic operation was performed at Massachusetts General Hospital in the mid-1800s, and that really allowed us to decrease the morbidity or the amount of suffering associated with trying to do anything for a breast cancer. So much of what was done before then, women had no pain medication or anything that really could put them asleep for any of the surgeries they were even undergoing. The second thing that we developed was the theory and the principles of antisepsis. So as I mentioned, we had so many women that died from infections after having a surgery that this was really instrumental in moving forward. Joseph Lister was an English surgeon who identified that carbolic acid could have some antiseptic properties associated with it. And he noticed this based on that's what they treated the sewage fields with during that time. And he thought that it would be safe because cattle that grazed those fields afterwards didn't seem to have any negative effects from being exposed to the carbolic acid. So what he did was actually start to ask people and surgeons on his team to wash their hands before and after surgery, to wear gloves during surgery. And they started to spray all the instruments and the skin of the patient with carbolic acid at the time of surgery to decrease the risk of infections. As we moved forward, this gentleman, Dr. William Halstead, was actually the person who was the most influential in breast surgery today. And so he's actually considered to be one of our fathers of general surgery. Dr. Halstead was a very unusual gentleman. He was actually addicted to both cocaine and morphine, both of which were legal during the time, but he was experimenting with those drugs, mainly with cocaine, to actually provide anesthesia for patients during surgery. Everyone on his team actually started using cocaine as a result, and out of all those people, only himself and one other person actually survived their addiction. One of his colleagues attempted to actually detoxify William Halstead by putting him on a cruiser across the Atlantic Ocean for a period of 2 weeks with the hope that he would recover from his addiction in that process. Unfortunately, when he returned to the United States, he was still addicted to cocaine, and it really did impact his professional encounters throughout the rest of his career. But what Dr. Halstead did for breast cancer was that he created the first standardized operation. So it was what we called the radical mastectomy, or what we in surgery call the Halstead mastectomy. At the time, this was still a very morbid procedure. So Dr. Halstead noted that the breast cancer survival rates were really impacted by what the extent was of the breast cancer when it was diagnosed. So the surgery that he did took off all the breast tissue, took off all the muscles underlying the breast tissue on the chest wall, and all the lymph nodes above the collarbone and in the armpit. So it was a very, very significant surgery, even for the women that underwent it. But what he started to see was that some women were surviving their breast cancers. So as opposed to the time of Dr. Paget, when 8 years out nobody had survived, Dr. Halstead was having rates of close to 40 to 45% of women surviving by 3 years out. What he did find, though, was that the prognosis was very much dependent on the extent of the breast cancer when it was diagnosed. And so he found that every single woman that he was doing the surgery on already had disease into what we call the axillary lymph nodes, or the lymph nodes underneath the armpit. And so he really felt that the problem that we were facing was the ability to discover tumors early. And he felt that if we discovered them early, that we would improve outcomes. Ultimately, this was the first situation in which we started to have hope that this could be a survivable or even just a treatable cancer at that time. His surgical technique of removing the entire breast and the muscles was unchallenged for close to 70 years, and well into the 1900s, that was still the mainstay operation for a breast cancer. As we entered the 20th century, however, we started to find that other adjuncts to surgery could be utilized to improve our outcomes. So we knew early in the 1900s that radiation could decrease the size of breast cancers, and some seemed to disappear completely. Same with hormonal therapy and chemotherapy. These are all three things that really integrally are tied into the treatment of breast cancer even today. As I mentioned, we started to see in the early 1900s that there was a curative effect of X-rays. And it was proposed as a sole therapy to be used in treating especially large breast cancers in the 1920s. But with the advent of the linear accelerator, that's when we really started to see radiation as a mainstay of treatment for breast cancer, especially ascending into the 1970s. Now it's one of the most common things that women will undergo, especially if they have a lumpectomy or a small portion of the breast removed. The rest of the breast is treated with radiation. And that's what's allowed us to really start to perform what we call a breast conserving therapy. And so vastly different and significantly advanced from where we were even 50 years ago performing a Halstead mastectomy. Hormone therapy is another adjunct to surgery that has dramatically improved outcomes for women. So we noticed early on that prognosis for women with breast cancer was significantly lower in our younger patients. And so what was done even into the 1900s and 1950s was surgeries to remove the ovaries, which is sometimes still done today. But even into the 1950s, we were also removing the adrenal glands. And so the thought was that we were removing all sources of estrogen in the patient's body to decrease the risk of them having their breast cancer come back, or just to treat their breast cancer. What we found in those patients where we had removed the adrenal glands and the ovaries was that some of them had dramatic responses, and others didn't seem to be affected at all. And ultimately, this discovery led to our understanding of estrogen receptors and how that has now impacted our treatment of breast cancer. Chemotherapy is obviously a significant portion of how we have managed to improve survival from breast cancer. Paul Ehrlich was considered the father of chemotherapy, and he had developed some of the early alkylating agents. During World War II, there was actually a warship that exploded off the coast of Naples, Italy, and it was containing nitrogen mustard. What we found was that the sailors that survived that accident had lower levels of bone marrow and lymphoid tissue in their bodies. And so that really was when we started to realize that we could use some of these agents to actually treat things like lymphomas and leukemias. And as we moved into the late 1900s, we've started to utilize chemotherapy in what we call a neoadjuvant, or essentially the primary treatment for some breast cancers. And even today we'll do that for women who have breast cancer that has spread beyond the breast already. Dr. Bernard Fisher was a gentleman who was the head of the National Surgical Adjuvant Bowel and Breast Project. So long title, but essentially this was the system that began clinical trials. So for all of our advancements that we have made over the last several years, so much of that is dependent on us having evidence-based medicine. And so how do we set up studies and trials for different treatments for women to really determine what is the next best thing? So the trials that he performed or that he arranged are what has allowed us to make advances in our surgical techniques. So understanding that we don't need to take out everything that Halstead did. We can do a lumpectomy. We just take out just the cancer. We can treat it with radiation afterwards, and that the outcome would be the same as if we had done a mastectomy. So all of that information, all those advancements are due to how we set up our research in looking at breast cancer. The biggest thing, and what I think is our biggest area to focus on here in October, is mammography. So like everyone that we've talked about has already mentioned, early diagnosis is the key. This is what Halstead said. Everybody who came to him already had axillary nodes, already had positive lymph nodes, and that he noted that the outcome was less in those women. It was very difficult to diagnose a breast cancer prior to World War I. Even as early as 1913, German scientists were identifying calcifications in the breast, but even at that time, we didn't yet understand their significance. So by 1948, we started to say, you know what, we might be able to find what we call an occult breast cancer, or one that a woman can't feel, but we know it's there based on an x-ray. But really, in the 1960s, MD Anderson did a study of over 2,000 women and found that if we do 2 x-rays, so 2 views for anybody who's had their mammogram, that we are able to not only identify breast cancers, but we're able to identify benign tumors and the difference between them with just an x-ray. And that is how the mammogram has become the most important diagnostic tool for identifying breast cancer. As we move forward, we've discovered that how a cancer behaves, or its biology, is very important. We discovered the impact of genes in the 1900s. So the BRCA genes, where we noted that some breast cancers seem to run in families. Maybe they had higher incidences of ovarian cancer as well. And so those things in general have given us increased advances to help treat women, diagnose cancers earlier, and hopefully improve survival rates. Even genes or receptors like HER2/neu have been discovered, which have also given us new information and new ways to target a breast cancer for treatment and going forward. As we've gotten so much better and have so many more options for women when looking at breast cancer and their surgical techniques, we've started this concept of reconstruction, which really focuses on survivorship. So we have 89% of women that are going to survive their breast cancer to 5 years. And so we want to make sure that your life at that time, you have good quality of life, because you're not going to die from your breast cancer. You're going to be around for a while. And so when we do your surgery, if we did a mastectomy, that we still have options to recreate your breast so that you still feel comfortable going forward. And you can do that with a flap, which is essentially moving skin or muscle from another area of your body, like your stomach or your back, or even doing breast implants. But ultimately, this really focuses on the concept that you're going to survive your breast cancer. And how do we make sure that your quality of life is now improved going forward, because you're going to be here going forward. So now today, about 70 years from when Dr. Halstead was still doing, or Dr. Halstead's mastectomy was still our standard of care, we now have multiple options for women, even just from the surgery standpoint. This isn't even encompassing the other options for radiation and chemotherapies and medications. But we have an option to do a lumpectomy for a patient. So we take out just an area of breast cancer and then treat the breast with radiation afterwards. Instead of taking out all of the lymph nodes in an armpit, we can take out just the 1 or 2 or 3 that would be most likely to have breast cancer in them. Because like we talked about, that's what gives us our prognostic factor, or we really understand where has the cancer gone to by that point in time. For women who do undergo a mastectomy, we have so many options for them to have a reconstruction to go on and still feel comfortable once they have survived their breast cancer. So where are we going to be next? There's so many advancements in every area of breast cancer. Our imaging is getting better. We have better techniques for getting mammograms. We have computer-generated programs that assist our radiologists with picking up minute details or changes in a mammogram. Our surgeries are advancing too. We're able to do surgeries where if we're doing a small portion, we can do it through what we call oncoplastics, where we can do it in a hidden incision so that women still feel comfortable going forward. We have so many more genetic testing that we can do. And we also have advancements in radiation. We're continuing to do all the same clinical trials that were set forth by Dr. Bernard Fisher, where we're looking at the best way to do something with the least impact to our patients. And finally, immunotherapy. This is an area that's not isolated to breast cancer, but this affects every cancer going forward, especially looking at how can we target breast cancers with the least amount of impact on patients and improve their likelihood of survival. Any questions from that standpoint? Okay.
Can you explain what estrogen receptors are and how they're used in the treatment of breast cancer?
Okay, so our question was that can we explain what estrogen receptors are and their treatment in breast cancer? So estrogen receptors are present on the surface of a breast cancer cell. And their impact, essentially how I explain it to my patients is, does your breast cancer grow in the presence of estrogen? Is estrogen like a fuel for your breast cancer? And if it is, what we know is that we have more options to treat your breast cancer. So a lot of women are on medications called tamoxifen or anastrozole. And those are medications that actually block those estrogen receptors. So if there's breast cancer cells somewhere else in your body, if there's one somewhere else in your breast, those medications help decrease the risk of those breast cancer cells spreading and essentially improve your survival.
What is the most promising treatment for breast cancer?
I think the most promising treatment for breast cancer is still revolving around our early diagnosis. So that's what this month is all about, October, okay? Breast cancer awareness. And so our most promising treatment is diagnosing it early. So that's why we need to get mammograms, okay? That makes a world of difference in where women are initially diagnosed and what their options are at that time. And so I'd say getting a mammogram is still our most promising way of decreasing our morbidity and mortality from breast cancer.
And this is the final question, unless anyone else has any other ones. What is a surprising fact about breast cancer that people might not know?
So I think one of the most surprising, our question was, what is a surprising fact about breast cancer that people might not know? And I think one of the things that I see so many of my patients say when they come in is, I don't have it run in my family, so I don't know how I got this, okay? And I think the biggest thing for us to remember is that our greatest risk of developing breast cancer is that we had breasts to begin with and we lived long enough to get a breast cancer. So it is not very common that patients have a significant family history. Certainly for patients who do have a strong family history, you might be at an increased risk of breast cancer. But the vast majority of us who are diagnosed did not have anybody else in our family who had breast cancer. Okay, any other questions? Okay, thank you again to everybody here at Southern Hills Hospital, and I think we'll sign off.